The importance of a multidisciplinary meeting like the EMUC, of course, has to do with the multidisciplinary approach of genitourinary cancers. And I had the chance in the former years to be in the scientific committee of this meeting and really have it fashioned in a way that it's adapted for medical oncologists, for radiation oncologists, also for pathologists and radiologists and imagers, next to the major group of the participants in this meeting, which are urologists. All the people in the audience, but also the people that are standing in front, can really imagine that genitourinary cancers today is not something done by a mono-specialist in his own hospital without interfering with the other specialties. The interaction that we have between all disciplines is much more pronounced in this meeting, where at each time you have a panel with the different specialists involved. There's a couple of interesting newcomers, let's say, hot topics and highlights. Once I would pick out maybe is the presentation on the screening, that we should probably stop screening people younger than 50, 55 years of age.
80 to 90% of men who would have died of prostate cancer would not benefit of starting screening before the age of 55. We can question whether a potential benefit for 10 to 20% weighs against the harms of advancing screening for all men before the age of 55.
Screening has always had a couple of criticisms. The most important is the overdiagnosis and the overtreatment, but also that very aggressive cancers with a screen PSA can be missed. If you start at 40 and you have a second sample of PSA at 45 and one at 50, then you can see that even patients that have low PSA when they're 50, they have doubled their PSA in the last 5 years. So they suddenly rise, and these are patients we need to be very careful about, because we will miss them. With the results of the study that clearly depict that you should not do population-based screening maybe before 55, there is certainly individuals that will profit of earlier screening that then needs to start at age 40. The use of multiparametric MRI has become so overwhelming. MRI is the advantage to see significant cancers, to probably not detect insignificant cancers, so this will help decreasing the overdiagnosis and possible overtreatment. On the other hand, if you have patients on active surveillance, you probably do not need to rebiopsy them each time. And also when you have to do surgery or radiation therapy, when you do focal therapy, MRI is of utmost importance because you see exactly where the tumor is. So MRI is of utmost importance. We need more MRI machines throughout Europe. The most important thing where we still need to improve from the meeting that is ongoing now and that is pretty successful, I must say, is we need to have more interaction with the audience and with the participants. And I believe for these people, this multidisciplinary interaction, you need to be able to have questions at least as long as the ex-cathedra presentations. We will have a meeting tomorrow with the steering committee and the scientific committee in order to continue to improve this meeting.